and all the teachers who are present. We are the second day of our bladder cancer program. And we will Dr. Ghosh to start the program in due course. Our president, Dr. Ranbir Prasad Singh, not just he was talking to me, he is in an OT. So, sir, please continue the class as it is scheduled. Dr. Ghosh, please.
Ghosh, I think it's in your background. We are a lot of noise. So if you can mute your sound, that probably maybe that is the source. Yeah. Good morning, everybody. I think we've got Rohit only as faculty. I think Debmallo will join. I don't know what has happened to Showman. Showman, I can't see him. But initially, we are going to discuss BCG. Initially, we are going to discuss BCG, then we're going to go on to MIBC, and then the steps of radical cystectomy. We'll give 1 more minute to Debmallo, and then I'll just give him a call, and then we'll start. In the meantime, I will share the thing of BCG. আচ্ছা কই দেখতে পাচ্ছেন ঠিক আছে can I ask the students to identify themselves? Who is it? Anik, you are muted.
Good morning, sir. I am Dr. Anik Ghosh from Arjikor Medical College and Hospital.
Who else?
Good morning, sir. I am Dr. Wasim from National Medical College.
Okay.
Good morning, sir. Good morning, sir.
Good morning. Who's that?
I am Dr. Wasim from NRS Medical College.
Okay. Can't see the Rohit or Debmallo. Are you there?
Oh, good morning, sir. I'm Dr. Sasi Prakash from RGA.
Okay, very good. Thank you. Can I see the faces of the faculty? Are they there? Rohit?
Yes, sir, I am there.
Okay. So shall we start? And is Debmallo there? Debmallo, are you here? You carry on? Rohit, you can carry on? Yeah. So first of all, let me just say what is the indication of BCG, and I ask Rohit to take this on with whoever volunteers. Is there any volunteer?
So,
who is answering this? Is there a volunteer?
any student?
Yes, sir. I'm Anik.
Yes, sir.
Yeah. Okay.
Who are
Indications for a BCG. We've been given the subject of doing intravesical BCG. So we'll start with indications. We'll go on to the mechanism, and then I will keep on going. So the opening question is, what are the indications of intravesical? Are you answering? Hear us?
Hello.
Anik, are you answering?
Yes, sir.
What are the indications of somebody take over, please? Any other student?
Sir, the indication of intravesical BCG is intermediate risks.
Who's answering?
Sir, I'm Anik Ghosh.
Anik.
Yes, sir.
There is too much background noise somewhere.
Start with the indication of BCG.
We can't hear you. We can't hear you. Can somebody else take over, please?
Sir, I am Dr. Asim.
Yeah, please carry on. The question is, in which cases of bladder cancer would you give BCG? And Rohit and Devbanlo are going to take this over from me.
Sir, indication of BCG in cases of intermediate and high risk bladder cancer.
Devbanlo, you're muted.
So what do you mean when you say high risk and what is intermediate risk?
Sir, according to UA classification, high risk and very high risk included any high grade tumor or any cyst changes, or along with these are the very high risk and very high risk and very high risk. Along with the others, the low risk category are the single tumor, less than
Listen to the question. Anik, you listen to the question. What is high risk and intermediate risk? I am not asking low risk. For BCG, intravenous BCG.
Ashim, can you put your video on? We can't see you.
Okay, sir.
Why do I have to prompt all this? I mean, we are in an age of technology. You should be faster than us. Have you woken up? Have you just woken up from bed or what?
Washim,
Yes, sir. Yes.
can you go ahead with your answer? What are the indications of intravesical BCG? 1, 2, 3, 4.
Sir, in cases of intermediate risk bladder cancer and in case of high risk and very high risk bladder cancer.
So what is intermediate and what is high and very high?
Very high risk category included those bladder cancer which is included high grade and very high grade tumor and associated with cyst changes.
So you
These are
want
the-
to G3 and CIS changes.
Yes, changes.
G3 and CIS changes. So there are only two indications, G3 and CIS changes. Any more indication?
Intermediate risk category also included for BCG therapy.
What is intermediate risk?
Intermediate risks are the tumor which is excluded low risk and very high risk and high risk. These are the intermediate risks.
What is intermediate risk? Clear answer.
So intermediate risks are that tumor size more than 3 centimeter, PTA, and multiple tumor, T1 low grade multiple tumor. These are the intermediate risk tumor. And any recurrent TA tumor within 1 year.
No, tumors who have carcinoma in situ, are they included in intermediate risk tumor?
No, sir, it is high risk category.
So the essence of intermediate tumor is it can be recurrent, it can be any kind of high risk and very high risk, but not associated with carcinoma in situ, isn't it? This is the
Yes, sir.
new UA 21 classification. So the essence of being a high risk and very high risk is that these patients must be associated with carcinoma in situ. Apart from 3 other criteria which is added. So UA 21 is this risk stratification is added for progression only who did not have BCG previously, isn't it?
Yes,
Yes.
sir.
And what is the criteria added for those patients who have already received BCG? Progression risk stratification. It's Cueto criteria. Who have already received at least 6 months of BCG, isn't it?
Adequate dose of BCG.
Okay. So coming back to Rohit Boss's question. So what is intermediate risk tumor? What is high risk tumor? What is very high risk tumor? So T3 tumor and carcinoma in situ. Now, any other indication?
Can you give BCG for residual tumor? Can you
Yes,
give
sir.
BCG for?
Yes, sir. I can give the BCG in case of cyst changes and residual tumor.
What residual tumor? TA or T1?
Sir, TA.
TA. So these are the indications: carcinoma in situ, high grade, or residual tumors, or TA which is more than 3 centimeter, or recurrent TA tumors less than a year, are the classical indications of giving an intravesical BCG. Devmalia, you add any more indication?
That is fine. That is fine.
Sir, one more question, ma'am. Sir,
Any? So
Sir.
now next question is, suppose a 60-year-old man has come for intravesical BCG. What are the important things you will see in history and examination? Before putting the patient on intravesical BCG, what are the things you will ask to the patient and what are the relevant investigations you will see?
Sir, I first determine details clinical examination, details history. If there is any history of any drug or immunocompromised drug taken along with it, if that patient has any history of previous tuberculosis or any history of any other disease, and yes, sir.
So history of tuberculosis, whether it is immunocompromised or not. Only these two history or any more history?
Also drug history, any other immunomodulating drug taken along with it, not it should be included along with the history. And during clinical examination, I will study ECG status of the patient, whether the patient ECG status, how the can take BCG or not.
ECG for giving intravesical BCG, I think you are mixing too many things. Sashi, will you add anything more in history? Immunocompromised patient, history of tuberculosis. These are the two things. Any more relevant things in history?
Sir, may I add, sir?
Yes, sir. Sure. Anybody?
Sir, I will ask the patient whether TURBT is done within 2 weeks or not, whether patient's urine culture is negative or not, and whether patients have any gross hematuria present or not, or whether is there any history of traumatic catheterization present or not, sir.
Very good. So,
Sir, one thing, urine culture not routinely required in case of asymptomatic patient.
okay, sure, but okay, it's fine if he says that urine culture should be ideally sterile before giving the patient on intravesical BCG. Okay, anything more, Devmali, I think you need to add?
The history of incontinence.
Yes,
Incontinence.
absolutely. A patient who is incontinent cannot be given an intravesical BCG. Number
Sir,
two is
liver disease also rule out.
Yes, liver disease.
liver disease
And
is
it's
a
not-
relative contraindications, but in absolute contraindications, you have to rule out whether there is any immunocompromised status of the patient, or the patient had a patient has an active hematuria or not, patient has an active infection or not.
My question was, what are the pre-op history and investigations? So, okay, I think we don't have anything more to add. So, Shashi, what is the procedure of giving BCG? How you give BCG and immediately 2 to 4 hours, what instructions you give to the patient?
So we have given some pre-BCG instructions. So we prescribe patient to limit water intake for a couple of hours before BCG installation, along with avoid coffee, tea, and diuretics.
Yes.
In pre-BCG instructions.
And how you give BCG?
Yes, sir.
How you give BCG?
Sir, patient, we still BCG either with the infant feeding tube or lateral catheter and the full aseptic precautions yes, sir.
After giving BCG, do you give any instructions to the patient?
Yes, sir. Hold urine for 1 to 2 hours and bleach toilet twice, flush toilet twice, and bleach toilet if you use this toilet.
These are the only two instructions, or any student would like to add any more instructions?
Sir, not to take any caffeine or any diuretic or any fluid before the installation of the BCG.
He has told that. Anything more?
Sir, previously it was advised that after installation of the BCG, patient should mobilize or change the position, but nowadays, sir, we only we do not advise these things.
So these are the only two things you will tell, that you hold it for 2 hours, pass it with bleach or anything more to the patient.
He or she should urinate in a clean area with bleach.
Yes, that he has told. Anything more? you should always instruct about the warning signs of BCG complication. Okay,
Yes,
if the patient is having fever, if the patient starts having hematuria, if the patient develops irritative blood, then he should immediately go to the hospital. The warning signs has to be explained. So, sir and Dr. Devmale, I think anything more to be added on this, or this is fine?
This is fine. This is fine.
Fine, let me just, before we forget it, what is the mechanism of IV BCG?
It was described very yesterday by in the slide. Anyway, for revision.
Somebody tell us in a nutshell. It was
Sir,
well.
BCG. Go ahead.
Yes, Shashi, any one student.
Sir,
Shashi,
intravesical BCG stimulate local immunity. Especially it stimulate interleukin 2, interleukin 6, which stimulate TH helper type of immunity, which mobilize the T cell, natural killer cell in the local area to control the tumor.
okay, one more question. Can you give the BCG that is used for vaccine as an intravesical BCG?
No.
These
No,
are
sir,
the
the strain.
The intravesical BCG that you use for immunization, the in kids, can we use it for intravesical BCG? Why
No,
and why?
sir, that's a
No, sir, probably the strain is different.
And anything more? The dose is very
Sir,
dilute.
strength is
Dose is
also
very diluted.
less
Uh,
bacilli.
Okay, and one final question. Can you give us some light about the doses of intravesical? Who will take this question?
Sir, first we gave after
What are the dose of BCG? What do you know about the dose of BCG?
Sir,
Who can share?
120 milligram per installation.
120 mg per installation. Any idea how much less you can give?
Sir, up to
Sir,
80.
up to 2/3, 1/3 dose can be reduced.
What is the lowest dose that you have heard of or you have read somewhere about intravesical?
60 milligram.
What?
60 milligram.
Okay, I was knowing 27.5. I'm not sure about 16. So I think that is enough for the dose. So Amit sir, you want to grill further or you would like to take it forward?
Yeah. The next question is, can BCG reduce the risk of progression?
Yes,
One
sir.
person answer, please.
Yes, sir. BCG can reduce progression of the disease.
So what is the evidence? Is it your opinion or is there evidence for it?
It is evidence based.
What?
Sir, SWOG study, Southwest Oncology Group study.
So it significantly reduces the risk of progression to muscle invasive and consider it to be the drug of choice for adjuvant treatment. Yeah?
Yes, sir. Yes, sir.
What is the evidence for maintenance treatment?
Sir, SWOG.
Need maintenance treatment. Do you really need maintenance treatment?
Sir, according to SWO study, maintenance dose of BCG should be given to give the full benefit of BCG.
So this
Okay,
is,
so the full answer will be coming back to the indication of BCG. What maintenance dose will you advocate in different risk category?
Sir, according to the recent EU guidelines of 2023, in immediate risk category, the maintenance BCG should be given up to the 1 year. And in high risk and very high risk category, it may be given up to the 3 years.
Yes.
Okay, so even after giving a maintenance dose, what is the amount of year after which those patients fail?
Sir, about 50% of
About 50% of patients fail. This is evidenced from even this SWOG study from LAMS regimen, isn't it? 50% of
Yes.
patients may fail after 4 years.
so what is the LAMS regimen? Let us start from the very beginning. What is the LAMS regimen? Come on.
Washim.
Yes, sir.
What happened?
Yes, sir. In induction course, we will start, sir, 6 cycles of weekly induction course. After, sir, that maintenance will be started from 3 months. Then, sir, 6 months and 12 months. Then after 1 year, it will be a maintenance course of six monthly interval up to 3 years, which are 3 cycles of BCG in 1 week interval, sir.
Very good. So, Demale, will you ask or should I ask?
So what is the total number of doses that has to be administered?
So one induction course of
So it
6.
is total 27 doses. What is the drawback of maintenance of 3 years of BCG? What is the
Many of the
drawback? Yes. Tell
many
me.
of the patients develop, sir, significant side effects, and also, sir, cost. It is costly, so many patients and drop out from that after 1 year.
So
Or
attrition
attritions.
due to BCG side effects, isn't
And
it?
sir, also there is some part of our country have BCG shortage. So the availability of the BCG also course the
That cannot be
that,
asked in an exam. Let's forget that.
BCG shortage is not a problem in our country.
Yeah. Don't discuss all this in an exam scenario. Okay. Whether it is shortage, whether it's costly, cost is not your concern. Why a 3 weekly maintenance?
because, sir, after 3 weeks the cytokines are reduced in the body, so we have to give a booster dose as a 3 month.
No. Why it is 3 weekly dose? Why do you not maintain BCG in a 6 weekly course? Why it is enough to give 3 weeks of course?
So 3 weeks or 4 weeks are, sir, are needed
So,
for increase of cell
Alvaro
mediated.
Morel's principle. What did Morel say? That the adequate immunity is developed even after 3 to 4 doses. But 6 doses were given because it was packaged like that, isn't it?
Yes, sir.
Yes, sir. Yes, sir.
So 3 weeks of doses is enough to boost up the immunity.
Why 6 monthly afterwards?
Why?
Why is it 6 monthly afterwards?
Answer is given in the screen.
You fellows must know how to cheat also. I'm giving you an open book.
Relative response persists as little as 6 months. That is there on the screen.
Sir, response of the 6 months is an important predictor of BCG failure.
No. The question is why 6 monthly? It is there on the screen. The response lasts
The cellular immune response declines after a period of 6 months, sir.
6 months.
So to
Next
give a
question is
boost.
what are the complications of BCG you know of? Any one person he will tell. Wasim, Shashi, Asim, or Yash. Any one person. What are the complications of BCG?
Sir, complication of BCG can be graded as a grade 1, 2, 3, 4. Grade 1 is consists of mild dysuria, mild hematuria, and fever lasting fever less than 38.3 degree, and this symptom all should be persist less than 48 hours. This is grade 1 reaction. You have a grade 1 complication. Grade 2 complication consists of a severe dysuria, hematuria, or fever less more than 103.4 degrees centigrade, and these symptoms should be persist more than 48 hours. And grade 3 complication or reaction means there is severe hemodynamic instability along with joint pain, fever, rash. And grade 4 is solid organ involvement.
Okay, so what is the treatment of grade 1 and grade 2?
Sir, grade 1 was only symptomatic treatment. We send the urine for culture to exclude any bacterial infection, and we include anticholinergic, antispasmodic treatment along with it. This is the only symptomatic treatment. Grade 2, it consists of dose reduction and along with urine culture, liver function test, and if this symptom recur, we can if fever persists, and we can use ionizing and rifampicin still the symptom persists.
Do you, till the symptom persists, do you give long-term AKT in some cases? What are the indications of giving long-term AKT?
In case of solid organ involvement, we can give at least 6 months AKT. In case of solid organ involvement, we can give ATD up to 6 months.
All the 4 drugs are given, or only 3 drugs?
One moment. I think
pyrogenamide is not given.
Yes,
Except pyrogenamide.
Background noise. Can you stop that noise, please, in the background? It's disturbing the whole interaction. Whoever is having noise in the background in their room, please stop that noise. Yeah, carry on. Sorry.
Sir, generally, pyrogenamide not used. Ionage, rifampicin, and ethambutol can be used for 6 months.
Okay, very good.
The next thing is, what is adequate BCG therapy?
So, adequate BCG therapy is either 2 induction or 1 induction and 1 maintenance, which should include 6 months of BCG therapy.
You agree with this?
Sir, at least 6 doses of induction plus 2 of out of second induction course, or 6 doses of induction plus 2 of the maintenance course, sir. That is adequate BCG.
6 doses of induction course has to be there. Is it true?
Now, in case of when patient taken 2 doses of 2 course of induction, in that cases, second induction should be at least 3 to 5 course. And in case of patient taken 1 induction and one induction and maintenance, then at least in case of maintenance, at least 2 doses of maintenance should be taken.
When do patients generally start complaining? In induction course, after how many BCG installations, generally patients start complaining about BCG dysuria? It's average 4 to 5 doses, after which patient starts complaining about BCG dysuria, isn't it?
Yes,
Whoever.
Yes.
So adequate BCG therapy is at least 5 of the 6 doses of initial induction course, plus at least 2 of the 3 doses of the maintenance therapy, or at least 5 of 6 doses of the initial induction course, plus at least 2 doses of 6 doses of second induction course.
Okay, so we need to be aware of adequate. What is adequate? What are we happy with? Let's go into the definitions of BCG failure. One person, please. Lots of confusion. What are the various forms of BCG failures that you know of? Who's answering?
Sir, BCG failure can be BCG refractory or BCG relapsing. And in BCG relapsing or...
What is the difference? No, don't confuse me. First of all, you clarify what you've said. Yeah, you're right.
Sir, BCG failure means during BCG therapy, any... Yes, sir.
What is BCG refractory?
Sir, BCG refractory means any patient who develop high-grade tumor during initial 6 months of BCG therapy. In case of TA tumor, in case of CIS up to the 6 months. In case of TA tumor, in case of up to the 3 months.
My goodness, you've confused everything. One line answer: persistent high-grade disease at 6 months, despite adequate BCG treatment. Are you in the habit of confusing the examiner? It's a good art, but you will have to face the patient. BCG refractory is after giving adequate at 6 months, you still have high-grade disease. So it's refractory. It's very easy. Don't have to put 3 conditions. What is relapsing? The word tells you what is relapsing.
So after completion of the BCG therapy, with completion of maintenance therapy, if any occurrence of high-grade tumor, then we will call it BCG relapsing, sir.
Say that again. Say that again.
So after completion of the maintenance therapy, if any high-grade tumor recurs, then we'll say it's a BCG relapsing, sir. It may be early, it may be late.
Basically, relapse of recurrence of the high-grade disease after achieving disease-free state at 6 months.
So what is
That boundary?
of the difference?
Yeah. Look at the difference. At 6 months, you are judging. If there is disease at 6 months, it goes into BCG refractory. If there is a period where at 6 months, there is a disease-free state at 6 months, then it comes back again. That's recurrence. There is a gap period.
So you have to achieve a disease-free state.
You have to achieve a disease-free state. That is the difference. Don't put 3 conditions and don't confuse yourself and the patient. Now, there is one more thing. What is the other thing?
BCG intolerance.
Yes. Unresponsive. Now, this is the new terminology. So BCG unresponsive, it includes both the BCG refractory and relapsing. Very fine difference. So the creators of these terminology are themselves confused, as you don't have to even attempt to confuse. Just now attempted to confuse, but the point is there is a fine line of difference between BCG refractory and BCG relapsing, which we just now discussed. In your own mind, it's fine to demarcate these two, but basically they are both now categorized as unresponsive. And that's the clinical decision. And the last one is BCG resistant does not exist. It's not currently used. So we are now left with 3. It's either refractory or relapsing, or it is unresponsive. Unresponsive is the umbrella of the previous 2.
Yes, sir.
Yeah?
Yes, sir.
Rohit, will you continue with what is to be done with the unresponsive non-muscle invasive bladder cancer?
So I will frame the question in a different way. Now you have a patient who has come after 6 months, and initial report was T1G3. You have given 1 induction and 1 maintenance. Now there are 2 possibilities, that there is a tumor, the biopsy is TA, or there is a tumor where the biopsy is T1G3. So how will you proceed?
Sir, in case of the TA tumor, we may give another induction of BCG.
Yes.
And if the patient responds, then we continue with the BCG or intravesical immunity.
Again T1G3.
Sir, in case of T1G3, it will be better for timely cystectomy.
So you will not advise a second induction chemotherapy?
No, honestly.
Sir, actually we can give a second induction chemotherapy, but that increases the chance of disease progression in case of 30% of the patient, and with a poorer outcome in a future radical cystectomy. So we will counsel, I shall counsel the patient.
That
Hello, sir.
is advisable. This may progress. So that is the answer. So anything more they will add?
Rohit boss, at this juncture, may I ask one question? What is, in case
Yes,
of
sure.
first induction BCG failure, what chemotherapy, what intravesical chemotherapy will you advise?
Sir, mitomycin C, sir.
Sir, valrubicin.
Valrubicin. Valrubicin is approved, FDA approved for this, but mitomycin C generally does not work. In case of mitomycin C failure, you can advise for an BCG induction, but after BCG induction failure, you always advise another BCG induction, or you may progress to valrubicin.
Yes, sir.
So in follow-up of after intravesical BCG, urine cytology generally doesn't work. Everybody agrees or not?
Yes, sir. Urine cytology generally get deformed.
When the patient will come for maintenance therapy, what are the investigations you will like to see?
Sir, urine cytology and cystoscopy. check
Yes.
cystoscopy.
Is it informative post BCG?
Yes, sir.
Sir, urine cytology may be misleading in post BCG. In that case, we can use NMP22 biomarkers, but that is not approved till now.
Before
No, sir. Sir,
22,
urine
any
cytology also. Sir, urine cytology also tells about the any other source, especially in upper tract. It can be source of another field changes.
discussed yesterday. I am specific about follow-up after giving induction BCG. Any alternative
Sir,
to
Sir, NMP22.
Or sir, fish, sir. Fish,
Sir,
sir.
Eurovision.
Fish.
Eurovision.
has been specifically recommended following BCG to see for malignant cells?
Sir, Eurovision.
That is fish, I think. Anything more that you would like to add?
The newer novel marker are there like epi-check or expert, sir, cancer expert.
Expert bladder and educate bladder are all actually chromosomal markers, so which is not very well available right now
Expensive also.
and very expensive.
That is the thing. So I think now the next question be about the patients who are not tolerating BCG. What are the options? Am I right, sir? Ghosh, sir?
Yeah, correct.
So suppose a patient is there.
First of all, I want to impress one thing. Look at this slide. So once the BCG fails, you have to swing the mood towards radical cystectomy. This is the only cure. Mind you, this is the only cure and your best chance. Rest of it are options. But this is a clinical judgment that you have to make. All researchers have shown radical cystectomy is the standard recommendation. Please do not be shy to say, I will offer radical cystectomy. However, there are options, and the options are only fit if they're unfit for cystectomy, mostly unwilling for a cystectomy, desirous of bladder preservation. There are various options available. So let us first discuss the various options. It's a very, very important question in your both Viva and theory. Rohit and Devmallo, both of you, please can you take over?
Yes. So if the patient is not tolerating BCG, what are the other options that you have?
The gemcitabine, epirubicin, doxorubicin.
And one of the options that Ghosh had discussed yesterday. Pembrolizumab. Am I right, sir?
Yeah.
And you should also know the dose of gemcitabine, mitomycin, and pembrolizumab that we use for intravesical therapy. At present, I don't remember it. If Demalia or sir remembers it, please highlight. What is the dose of gemcitabine and what is the dose of schedule of gemcitabine, MMC, or pembrolizumab when you are using as intravesical therapy?
The NMC dose is 40 milligram per 20 ml.
And what is the schedule?
Hello, sir.
What is the schedule?
So there is no standardized schedule at present. It may be given at 4 weekly or 6 weekly.
Okay. So,
Some background television is going on.
Yeah, I'm repeatedly telling them to stop whatever the background noise is coming. The audience, please, you can't have it both ways. You can't listen to this seminar and do a recreational television at the background. Please stop the noise. So these are the treatment options, but let us proceed from here. You see, first of all, a repeat BCG is an option, as you said. It's a bad option, but it's an option. Intravesical chemotherapy is now the in thing with gemcitabine, whether you add MMC together with it. The more important thing is thermochemotherapy. Taxane therapy, docetaxel, paclitaxel. electromotive drug administration. Now, what are the strategies of BCG refractory cancer? You can boost the immune response. You can use Mycobacterium cell wall DNA complex. Valrubicin has already been mentioned. Gemcitabine, mitomycin, doublet intravesical chemotherapy, and docetaxel. So these are the various strategies for which you can use in BCG failure. If we're asking about the dose, this is what it is. Have the students disappeared or what has happened? I can see Dhananjay Kumar here. Shashi, are you
Hello,
okay?
good morning. Yes, sir.
Yeah. So this is what the management of BCG failure is. Deepmallo and Rohit want to add anything more? Otherwise,
So what is a sequential therapy? Sir, can we get back?
Yeah.
Get 2 slides back to the options of another slide, sir. The list of yes. No, another more. Yes. So can you tell me what is a sequential therapy? That is also mentioned a few points above that. What is a sequential therapy for BCG failure? So if you add mitomycin C with gemcitabine in a specific order, that becomes a sequential therapy. So will you add mitomycin C after gemcitabine, or you add gemcitabine after adding mitomycin?
Sir, I will add mitomycin C after gemcitabine.
Why?
Because mitomycin C is viscous and it will irritate the bladder. So if I instill mitomycin C before gemcitabine, the patient cannot hold gemcitabine after that. So I will add first gemcitabine, and after that 2 hours I will ask the patient to void, and after that I will add mitomycin C.
Very good, very good. Sir, can we proceed? Hello.
Hello.
Rohit boss, please proceed.
So I'm not able to see anybody. Am I audible?
Yes, sir.
Yes, sir.
So I think BCG has now been covered. I think enough. Now we should proceed to the next step about BCG failures. Roshar, am I okay?
Yeah.
So I think the next topic will be about the steps of radical cystectomy, if I am not wrong.
I think we go on to MIBC and then finish with radical cystectomy, because at the end of that discussion, radical cystectomy comes in. So I will stop share. Deepmallo, will you share the MIBC or shall I share?
You share, sir.
Okay. Just give me a moment. We will discuss the MIBC separately. At the end of it, we'll go through the steps of radical cystectomy and we close today. Deepmallo, describe a case scenario for this particular one.
Okay.
I'll show you just now.
So this is a 65 years old gentleman who has been a smoker, who had TURBT 3 weeks back, which comes out to be PT2 high-grade bladder cancer, TCC, with lymphovascular invasion. So he was asked to do a CT urogram 4 weeks after that, 3 or 4 weeks after that, and the CT urogram comes out like this. Can anyone read the CT? Wasim?
Yes, sir. Sir, this is sir plate of sir's CT urography phase showing
What phase?
Europe delayed phase, sir.
Okay.
Delayed phase
Delayed
shows
excretory phase. Yes.
delayed excretory phase shows, sir, a solid growth in the left lateral wall of the urinary bladder, which, sir, with extravesical extension, and there is few lymph node is also seen. Probably the, sir, obturator lymph nodes are enlarged in the left side, and also, sir, right side also few lymph nodes are seen, and the rectum is free from the bladder wall, and the other surrounding structures are apparently free from the, sir, bladder.
Okay. So these are the other cuts. Can you see anything else? Describe the bladder first. This is not the delayed phase.
Yes, sir. This is
No. Previous one, sir. Sir, previous one.
this is the arterial phase of CT scan. CT scan of CT scan KUB of the bladder cut section shows, sir, a large heterogeneous mass covering the left side of left lateral wall, extending to the anterior wall of the bladder. With, sir, some perivesical fat stranding, and there is, sir, also, sir, a left-sided ureteral dilatation.
Okay. So left ureter is dilated, isn't it?
Yes, sir, and, sir, few lymph nodes are also seen in bilaterally.
Are you able to see the lymph nodes?
I don't know.
How you see lymph nodes on a CT scan?
Sir, lymph node at the level of acerabulum, beside the
Yes, sir.
vessels.
2, 3. As a third row, sir. Second picture, sir. Few, sir, enhancing, sir.
Wasim, how do you see? Why do you find the lymph nodes?
How do you
Research was asking, why do you find the lymph nodes?
How do you assess the lymph nodes on a CT scan?
Sir, at the cut section of the, sir, head of the femur over the, sir, obturator internus muscle, sir, lymph nodes are seen in, sir, nephrogenic phase, sir, arterial phase or nephrogenic phase.
No, my question is how you assess. What is the basic idea? How you assess? You have to follow the blood vessels.
Yeah, yes, sir.
And along the blood vessels, if you are seeing an oblong structure which is persisting for more than 2 or 3 cut, then only you think that it is a lymph node. What is the difference? Other structures.
Can't hear you, sir. Excuse me, sir.
See, if you are seeing a oblong structure in 1 or 2 cut, what it can be other than lymph node?
It may be, sir, obturator vessels.
Yes, it can be. Make sure that it is not a vessel. That is the way to assess a lymph node. So,
what is the parameter of a lymph node being a or a benign?
Sir, one of the size of the, sir, if pelvic lymph node more than 8 millimeter or abdominal lymph node is more than 1 centimeter.
What are the other criteria?
The shape of the lymph node. If the reniform shape of the lymph node is lost, then there may be deposit of micrometastasis in the hilum of the lymph node. In case of positive lymph node, the lymph node may be globular rather than reniform lymph node, which is seen in normal cases.
Okay.
So around more than say 8 mm is generally suggestive of pathological involvement. So the next question is that what you will advise to the patient? Suppose this is the same as a 60-year-old gentleman with no history of smoking, and the biopsy comes out to be muscle invasive bladder cancer, and you are seeing lymph nodes on a CT scan. What you will counsel to the patient, or what will be your principle of management?
Sir,
Sir, the
he-
principle of the Sir, the principle of the management, I will counsel the patient about neoadjuvant chemotherapy, and after that, I shall counsel the patient for radical cystectomy with urinary diversion.
If the creatinine is 1.7,
The
GFR
creatinine is
or 50.
May I just interfere one moment? I think you're right. Onik, you said neoadjuvant chemotherapy, isn't it?
yes, sir.
But tell me something. That's not its definitive treatment, is it? What does, you have to be very clear. Yesterday was the day of NMIBC. Today is the day of MIBC. So yesterday, management was endourology. Today, the management is radical surgery. If you do not mention radical cystectomy as your philosophy, however much you might say neoadjuvant, this, that, and the other goes into the Ganges. So first answer is this. Whatever you do, the rest of it is absolutely right what you said. Please do not forget and do not be shy to say MIBC equates with radical cystectomy, whatever happens.
Okay, sir.
Now the debates we will come to a little later. The debates about whether it's neoadjuvant, adjuvant, what is the role of bladder preservation, fine. But the banyan tree ka trunk jo hota, that trunk today even is radical cystectomy. Please do not forget to say this, that your philosophy is radical cystectomy. Now, whether we are going to do neoadjuvant, whether we're going to save the bladder, whether we're going to do this, that, and the other, we will come to that later. Okay? So just a word of warning. Now,
so what are the options for neoadjuvant chemotherapy?
Cisplatin, gemcitabine, or MVAC regimen.
MVAC regimen. And if the creatinine, if the GFR, estimated GFR is say for 50 ml per minute, then?
If the estimated GFR is less than 60 and or performance status ECOG is equal or more than 2, then we can replace cisplatin with carboplatin, though it is less efficacious than cisplatin.
I don't agree. For a neoadjuvant, it has to be a cisplatin based, otherwise carboplatin will go in the adjuvant setting. For neoadjuvant, carboplatin is not advised. Am I correct, sir?
Now, before that, I want to ask him one more thing. Why? What is the role of chemotherapy in advanced bladder cancer? Why do you want to give it?
What? Why?
Sir, in case increase the
said that
overall survival 5 to 8%.
5-year survival 5 to 8%.
That's all. So you have to speak the modern urological language. Yeah.
That it downgrades
This is the trial that changed direction. There are other trials also. This is the trial which brought in this concept of neoadjuvant, where MVAC with RC and lymph nodes versus surgery alone. Look at the overall survival difference. 77 months versus 46 months. Now, this is the evidence. This is a very strong, irrefutable. And second thing, you have to talk about pathological T0 after neoadjuvant. Pathological T0 after neoadjuvant is 38%.
35 to 40%.
As opposed to 15% in the surgery alone. Those days are gone when you can give surgery alone, if you can help it. Please make this concept. You are now existing in 2023. So you have to talk about these two issues. The overall survival is way ahead of surgery alone. Secondly, the incidence of achievement of pathological T0 is way ahead of surgery alone. And it has got a significance. The 5-year DFS is 85% in T0. You cannot deny this. So the philosophy about neoadjuvant is remarkably different. Now, the question to you is, the googly question to you is, you've given neoadjuvant and the patient has achieved T0. Now the patient comes to you, T0, and the patient comes to you and says, I don't want surgery. What do you do? Anyway, I'll let you carry on with the chemotherapy that was being discussed. Rohit, carry on with the treatment. I think I just wanted to interfere with the concept of neoadjuvant. What are the options of neoadjuvant now? Rohit, please click on. We need to discuss the neoadjuvant. We need to discuss the adjuvant and we need to discuss the management of lymph nodes.
Okay, what is the fallacy of neoadjuvant? Why some people are not convinced? What are the drawbacks or what is the other side of neoadjuvant? Sir has told about the pathological response, the survival and the T0 state, but why still it is not followed in every center and what are the criticisms against it?
First, sir, in case of when we given neoadjuvant, actual surgery may be delayed.
When the surgery may be delayed, the performance status of the patient may go down and the surgery may be delayed. Second,
So tumor may not be responsive to chemotherapy,
yes,
surgery is delayed.
responsive to. So what is the dose? What is the dose and schedule of neoadjuvant chemotherapy?
So 3 doses.
3 or 6?
6 doses.
3 or 4 doses.
Sir, 3 or 4 doses. At first, we give 2 cycles, and after that, we shall assess the patient if the tumor is responsive. If it is responsive, then we can give 1 more dose and proceed for radical cystectomy.
Yes, very good. After giving 2 or 3 cycles, you have to again do a check cystoscope to see whether the tumor is progressing or not. If the tumor is progressive, that means the patient is not responding to chemotherapy and the patient should be taken for radical cystectomy as early as possible. So now the next question is, for patients who are chronic kidney disease, whose GFR is less than 60, do you still will you give carboplatin as a neoadjuvant or it will go in the adjuvant setting?
Adjuvant setting.
Yes, it will go in the adjuvant setting. And things were discussed yesterday by sir that now even pembrolizumab is being tried in a neoadjuvant setting with very good results. So these are the things that is there. So sir, please highlight on the doublet regimen the slide that is there.
So the option for MVAC today is this. You agree with this? What happened? Avik, you have turned yourself upside down. What happened?
Yes,
sir, the phone falls.
Yoga or something?
No, sir, the phone actually falls from my hand.
Oh, okay. Deepmal, are you there?
Yes, sir.
Okay, so the doublet regime is another option. Similar efficacy. The reason the doublet regimen has now come into vogue is because of the improved tolerability of GC compared with MFAC. The median survival of 14 months versus 15 months of MFAC. So it is similar, but the toxic death is 1% for GC and 3% for MFAC. Pathological complete response rate is absolutely the same. So this doublet regime has gained popularity because of the toxicity and tolerability. I have to have another word about the adjuvant. Upfront or immediate adjuvant chemotherapy is a question that you will face. So no improvement in OS compared with the deferred adjuvant. Prolonged PFS with immediate compared with deferred chemotherapy. These data form the rationale of offering adjuvant chemotherapy to patients with locally advanced T3 and or node-positive bladder cancer who have not received prior cisplatin-based chemotherapy. So neoadjuvant chemotherapy and adjuvant chemotherapy in the setting of muscle-invasive disease is an extremely important subject. It is not only important to know what you will do, it is not only important to do the negatives. In India, you know, you tell them neoadjuvant, they will get a little better and they will run away, their health will deteriorate. These are the negatives. But in the science of it, there is a remarkable difference in MIBC between the neoadjuvant and no neoadjuvant. Deepmalla, will you take over for the lymph node discussion, please?
Before lymph node
Sir,
discussion,
Sir, one question, please, sir.
Yeah, any other questions? Yeah.
Sir, how many cycle adjuvants have we given? Hello.
It's 4 and 6. It depends upon the centers. Some centers give 4, some centers give 6. But generally, you should do a check cystoscopy after 2 or 3 cycles to see whether the disease is progressing or not. That is very important. If the disease is progressing, then
no,
you
he
should
was asking for adjuvant or new adjuvant.
Adjuvant.
He was
What?
asking for adjuvant.
Adjuvant.
Adjuvant is
How many
generally
cycles?
3 to 4 cycles.
3 to 4 cycles. Okay, sir.
No, the principle of neoadjuvant therapy, even after the SWOG study, which used, extremely toxic drugs, what is the principle of neoadjuvant therapy? It's one of the principle is downgradation of the disease. What is the other principle? Why this idea of neoadjuvant therapy came?
Sir, take
came
care
into
of the
vogue?
micrometastasis.
So MIBC is taken, muscle invasive bladder cancer is taken as a systemic disease rather than a localized disease, isn't it?
Yes, sir.
This is one of the
If
principles.
we can also assess response to chemotherapy also.
Yes, we can assess response to the chemotherapy, but that is a different question. Why the principle? What is the principle behind using a neoadjuvant chemotherapy? Is that now?
Yes.
If we come back to the lymph node dissection, sir, can we include the lymph node dissection in the steps of radical cystectomy?
I think that will be better.
Yes, sir.
So now we should start discussing radical cystectomy. The operative steps and the lymph node dissection will be included in that.
Whether it should be done or not, the extent of it, can you discuss it now and finish it in 2 minutes, and then we can proceed. Should be
Okay. So there is an the principle of doing a radical cystectomy is that you include lymphadenectomy as an integral part of the radical cystectomy. That the name of the procedure cannot be only radical cystectomy. The radical name itself includes the lymphadenectomy. Now there is a doubt about, or there is confusion about whether this lymphadenectomy is therapeutic or diagnostic only. In case of radical cystectomy, the aim is to have a therapeutic goal so that you can control the locoregional disease. But the extent, again, there is confusion about the extent of the lymphadenectomy, isn't it?
Yeah.
So someone can someone tell me about the?
Deepmalla, ask Ashim. Ashim, are you there?
Yes, sir.
What are the boundaries of lymph node
How much
dissection?
lymph nodes do you want to remove?
What
How
is
much
standard lymphadenectomy?
and what is the number?
Sir,
What are the
Sir.
boundaries? What is the number?
pardon, sir, please.
What are the boundaries of lymph node dissection?
Sir,
What-
boundary. There are 3 types of lymph node dissection. Standard.
No,
No, you tell me
super
the-
Very question.
tell
What
me the standard of.
do you want to select? Do you want to select extended
Standard.
standard?
Standard.
Why not an extended?
The extended also can be selected.
You change your mind and super extended?
Sir, generally extended is better than standard because inside the common
What is
ilia
the
group of
logic?
lymph node.
What is the logic?
Sir, the common ilia group of lymph node has been involved is seen in 10
the
to
answer.
15% of the cases.
Boss, this is the answer.
So
You have
now,
to agree to this. This is not my verdict. This is a researched conclusion. Okay?
So,
You look at the data. This is the researched conclusion. There is no survival benefit. You can or cannot.
so what are the boundaries of a standard lymph node dissection?
So from the upper limit, from the common iliac bifurcation up to the
Yes.
lower limit will be the circumflex iliac vein, laterally from the genitofemoral nerve and medially up to the internal iliac artery on both sides.
Internal iliac artery or the genitofemoral nerve?
So genitofemoral
Lateral
nerve on the
Medial
lateral
boundary. He
side.
was telling about the medial boundary.
Obturator nerve, sorry.
Hmm.
Obturator, what am I saying? Not genitofemoral.
So laterally,
Genitofemoral.
Genitofemoral.
You have to go
genitofemoral.
femoral, distally up to the femoral ring or the circumflex iliac vein, inferiorly up to the obturator nerve, and superiorly up to the midpoint of the common internal iliac artery. I think I am right, Devmalya and Ghoster?
So generally, we take internal iliac artery as the medial boundary.
Medial and
Obturator nerve has to be completely skeletonized so that obturator fossa is seen well. But sir, we generally go up to the internal iliac artery.
Okay. And what are the other structures that you will be able to see? Any comment about the presacral lymph node dissection?
In standard lymph node dissection, we generally do not include presacral lymph node dissection. But in extended lymph node dissection, presacral groups are included.
Okay, and now coming back to what Ghosh sir has said, there is no survival advantage of extended or super extended lymph node dissection, but generally which group of patients these lymph node dissections are recommended? There can be two kind of per operative picture. In one picture, you will go for a standard lymph node dissection, and in another, you will go for a extended or a super extended. What are the group of patients in which you will go for extended or super extended lymph node dissection?
If lymph nodes are positive intraoperatively, we have not get lymph node positivity beforehand. But in intraoperative, if lymph nodes are positive, then we may go to the
Yes,
extended lymph
coronal
node.
section positive or more than 1 centimeter grossly pathological lymph nodes. These are the indications for doing a super extended lymph node dissection. And now the next question is, what should be the total number of lymph node count? There is a count and there is a density. When you finally see the histopathology specimen, is there any importance of the count and the density?
Yes.
So count
Yes,
is
sir.
at least 10, sir.
10, sir.
At least 10.
At least
At
10,
least
sir.
10. Sir, at least 10,
density.
preferably 25.
Yes, I think the Campbell mentions preferably it should be more than 25
Yes, sir.
for doing the total number of lymph node counts to assess whether the lymph node dissection has been complete or not. Actually, now what is the ideal standard? There is a lot of confusion. If you hear Dr. Ghoni, he says that the obturator nerve, the internal iliac vessels, and even he says that the iliolumbar trunk should be visible when you have done the lymph node dissection.
Now, I will nearly end the session. I just wanted, for the sake of completeness, I wanted to just show you 3 or 4 comments. What is no survival benefit? We must remember this. However, when you say standard lymph node dissection, standard template identifies up to 95% of lymph node positive patients. Positive lymph node rarely skips. The skip percentage, this is the rationale, is 0.6 to 5%. So what is the rationale for extended and super extended? 6.43% of all positive lymph nodes are found above the standard lymph node field based on mapping studies. This is based on mapping studies. Yeah. Systematic review shows no survival benefit. However, there is an increase in the adverse outcomes in terms of operating time, blood loss, length of stay, and post-op complications. This is your exam answers to defend yourself. Okay, we close the chapter on this. We go on to the steps of radical cystectomy. One of you please volunteer. We want you to face the steps. Let me just Demal, are you going to share or shall I?
Sir, please you share.
Okay, carry on.
So, can anyone volunteer? So let us start the discussion with the indications of doing a radical cystectomy. Can anyone volunteer?
Sir, in biopsy, TURBT specimen shows T2, T3, T4A disease, and sir, BCG refractory or BCG unresponsive, or any variant histology like squamous cell carcinoma or micropapillary variant, then we shall go for radical cystectomy.
Excellent. So any other relative indication of doing a radical cystectomy?
Sir,
The tumor is large, not accessible by endoscopic resection.
Large TA tumor.
Not accessible to complete resection by endoscopic method.
Very good. So these are
Sir,
the relative
Sir, in recent EAU guidelines 2023, very high risk group of the patient are directly counseled for radical cystectomy, and if they refuse radical cystectomy, then we can proceed for BCG therapy as per their guideline, recent guideline.
So, sir, next slide, please, sir.
Oh, sorry. Sorry.
So, so the standard indications of doing a radical cystectomy is T2 to T4A, N0, M0 disease. It might not be an N0 disease. Very high risk non-muscle invasive bladder cancer, BCG refractory, BCG relapsing, and BCG unresponsive non-muscle invasive bladder cancer, and special histology variants. The relative indication is extensive papillary disease that cannot be controlled with TURBT alone and intravesical chemotherapy or immunotherapy alone. So, sir, next slide, please. So, when you are convinced, so previous one. So, when you are convinced, what checklist will you go through before going or before taking a patient for radical cystectomy?
Before radical cystectomy, I should assess operative fitness, the ECG status of the patient, whether the patient can be withstand the radical cystectomy, and also we can the renal status, whether how the pouch should be done, either ileal conduit or neobladder. What is the primary tumor location, whether it is away from the bladder neck or urethra or close to urethra.
So, so you want to exclude whether you are going really for an radical cystectomy or you want to add an urethrectomy to that, isn't it?
Yes, sir.
So, what are the indications of doing an urethrectomy?
Sir, in case of male patient, involvement of prosthetic stoma involvement. In case of female patient, involvement of bladder neck is the indication of urethrectomy along with radical cystectomy. And in case of extensive cyst changes, we can also include urethrectomy.
Include extensive carcinoma in situ changes where?
Bladder.
Prosthetic urethra. Prosthetic
Prosthetic
urethra.
bladder and bladder.
Not only bladder, if it is only carcinoma in situ changes inside the bladder, you can pretty well do an radical cystectomy alone. But if the carcinoma in situ extends inside the prosthetic urethra, then you will add an urethrectomy to that. Before that, do not forget to mention the stoma marking, the reservation of blood and blood products, and explanation of the procedure to the patient so that see whether he has good dexterity and whether he can maintain his orientation after the procedure or not, isn't it? So let us come back directly to the radical cystectomy. What?
How will you mark site pre-operatively?
Yes. How do pre-operatively mark the site of stoma? Anyone?
Sir, patient should be marked in the standing position in the line joining from the anterior superior to the umbilicus, avoiding the bony prominence.
So, is it really marked in the standing position, or you can mark it both in standing and in sitting position? Because when the patient sits down, the canvas of the abdomen actually folds over his thigh, and the stoma, the bag, can get dislodged from it, isn't it?
Yes, sir.
This is the
So
idea.
generally, if you mark it in the operation theater before induction, you mark it while the patient sits on the operating table.
Yes, that is true. You should assess both in standing and supine position, and then you should mark. It should be away from bony prominences. It should away from any scars that are there or a falling panel. So you should assess both standing and supine in the pre-operative day -1. And you should always, if your hospital has a stoma consultant, you should involve that person when you are marking a stoma.
Yes, sir.
Okay. So what is your standard position of doing an radical cystectomy?
The supine position with slight 10 to 15 degree tender back position.
No. Will you counsel the patient about orthotopic and an ileal conduit? Will you have a word in which patients you will go for orthotopic, or what are the
Yes,
conditions
sir.
not go for orthotopic and you will go for ileal conduit? The patient will ask
Yes,
you.
sir. Yes, sir. Yes.
So what you will
No. What are the patients? Who are
In
those patients with whom you will discuss about orthotopic diversion?
patients in which you will discuss about ileal conduit?
Ileal conduit.
Both. Which patients will go for orthotopic and which patients will go for ileal conduit?
Sir, young patient, sir, young patient with a good renal reserve and negative for urethral biopsy.
What is good renal reserve? Good renal reserve is not an answer. You should speak in terms.
Sir, creatine less than 1.5.
Or GFR more than 60.
More than 60.
Yes, one. Then GFR should be more than 60. Another?
And in case of male patient, posterior stromal, no invasion of posterior stroma. In case of female, negative biopsy from bladder neck.
Yes, very good. What about
and there is a gross tumor should be completely resected.
No, this is not an answer. Renal reserve more and the bladder neck, the prostatic urethra frozen section should be negative. These are the two indications for doing orthotopic neobladder. What about female? If there is any female patient and you are planning an orthotopic, what you will explain to her? Is there any difference between male and female patient regarding orthotopic, or both the patients are same? Any other person? Sashi, Vashi?
Sir, in female patients, the bladder, neck, or the proximal urethra should be free in the frozen section, paraoperative frozen section.
I'm telling you, the GFR is more than 60, the frozen section biopsy is negative. Are the two patients different? A male patient and a female patient?
Sir, female patient may be incontinent.
Do everybody agree, Vashim, Sashi, that doing a orthotopic bladder in a female, the patient will become incontinent?
Maybe possibility.
No, sir.
So a male patient can be incontinent as well. So who are those female patients who has possibility of having good result after an orthotopic?
Sir, in whom vaginal vault and uterus has not been involved, or female genitalia can be preserved. In that case, the orthotopic neobladder will be a good result.
See, what is the problem after doing an orthotopic bladder in female? What is the problem with them as compared to male? See, male patients can void after doing orthotopic, but generally in female, at times that there is a urethral kinking and the patient has to be explained about the need of CIC.
Yes.
It's more common in females as compared to males. Males may also need, but generally males are able to void, but not in females. Females may need a CIC. So when you are explaining orthotopic, the patient has to be counseled about the need of CIC when she is going to underwent a orthotopic neobladder. Now, next question, which are the patients in which you will not go for orthotopic, and pre-operative you will say that I will go for ileal conduit?
First is patient GFR is less than 60 and creatine patient and with loss of dexterity.
Contraindication for doing orthotopic. Is it mentioned in DFR? Okay, yes. Creatinine is more than 1.5 and
The
Loss of
prosthetic stromal
dexterity,
involvement.
manual dexterity.
if the frozen section is positive,
Prosthetic
if the
stromal.
prosthetic or the urethral involvement is there, these are the contraindications of doing a ileal therapy. Even in diabetics, long-standing diabetics, people generally avoid the orthotopic because they have got a recurrent history of pyelonephritis. But though it is not a standard way, but generally people avoid. So Devmali, I think we should now proceed with the steps.
Yes. So it is generally told in your textbooks that the patient has to be placed in an hyperextended position with an fulcrum at his lower back. But generally, we prefer to do the patient in a supine with 10 to 15 degree Trendelenburg position. Do we agree about this, Rohit boss?
Yes, we generally prefer a supine position with a Trendelenburg with the hip is raised. You know, the table are tilted on both the sides.
Yes.
Pubic is raised and the patient is in supine position.
And what is why can anybody tell me why, when is the situation when do you place the legs on a stirrup?
Yes, when this position is given, which is mentioned in the slide, which is Devmale is showing on the slide. When this
When we need urethrectomy along with radical cystoprostatectomy, then this position may be needed.
And in case of maybe this position may be needed in case of females when you have to put an gauze with swab inside the vagina.
Vaginal pack. Yes, sir.
Yes.
Vaginal pack.
When you have to need some mobilization. Sir, can we go to the second slide, please? Next slide, please. So let us keep it short. So incision, what is your preferable incision?
The midline vertical incision.
What are
Up
the
to what?
incisions that have been described? This is an example. What are the various kinds of incisions that has been described for doing a radical cystectomy?
Yes.
Midline vertical that you are able to see here. What are the other incisions? Asim, Washim, Sashi, or any other incision you know of, or only one incision? Vertical midline incision. You can do even with a fenestrine where the
yes
on the pubic symphysis. That is an
So-
also that has been described.
So what up to what extent would you like this incision to be? What will be your cranial extent? What will be your caudal extent? And why is that?
Sir, from the upper level of the umbilicus up to the level of the symphysis pubis joint.
Is it how do you describe, how do you determine what is the level of the symphysis pubis joint? When you deepen the incision, this is the practical point. When you deepen the incision, will you leave it at the say pyramidalis muscle or
No, sir, I will extend the incision till I feel the bones.
Yes, absolutely. And what will be your cranial extension?
Sir, above the level of the umbilicus to include the urethus. Complete mobilization of the urethus from the umbilicus will be my target.
Okay, so exactly at what point will you deepen this incision? What is your practice? At the caudal end or the cranial end?
Cranial end, sir.
Cranial end, sir.
And what do you do next?
Sir, mobilize the urethus from the umbilicus.
Assess the operability of the tumor, whether it is operable or not. After opening the abdomen, you first assess.
Sir,
how do you assess the operability of the tumor?
Sir, you first we assess any bony fixity. Sir,
you do not go rightly. You do not immediately go to assess the operability of the tumor or fixity of the bladder.
So we will
But
open
you
the
have to
sir.
do something to open the peritoneum.
We will sir open the space of radius first and laterally we
What
will
to do
mobilize.
before going to the space of radius?
Sir, we will have to incise the rectus sheath and separate the rectus muscle, and then by opening the space of radius, we have to sir mobilize the bilateral lateral wall of
So
the
your
bladder.
be that I will deepen my incision up to the fossa transversalis at the cranial end of the incision and try to include and dissect the uricus and the obliterated umbilical vessels and secure it. Only after that, if this is a really transperitoneal approach, which is done mostly in all our centers, if it is a transperitoneal approach, then we will secure the uricus and the obliterated umbilical. When we keep on opening the peritoneum and get to see the bladder and get and hold on the dome of the bladder, then we add the operability of the tumor, is it? So there are lot of background.
Sir, not audible.
Huh?
Not audible. Sir, background noise.
Okay.
Yes, sir. Audible. Audible, sir.
Okay. So say this is operable. Then how do you extend the incision? What is your goal of extension of the incision and deepening of the incision? So you follow the code on obliterated umbilical artery bilaterally, not only the uricus, to reach at what point bilaterally?
It's a deep inguinal ring.
Very good. So up to the deep inguinal ring. So next slide, please. When you reach from deep inguinal
video.
Hello. When you reach the deep inguinal ring, what structure do you
So vas deferens as spermatic cord.
Then what do you do?
We will say dissect the spermatic cord and ligate it and divide the spermatic cord.
You do not encounter the spermatic cord here. You encounter the vas deferens here, isn't it?
Yes, sir. Vas deferens.
And you extend the peritoneal position up to the lateral side of the urinary bladder, isn't it? Bilaterally. And you leave it like that. You place a clamp and keep it under traction. Then what do you do?
Sir, then in right side, sir, after sir, cecum should be reflected upwards, and sir, peritoneum should be sir opened up to see the iliac vessels and look for the ureter, sir. And then we loop the ureter and both side, right side after that left side, and dissected up to the sir VUJ and look for the superior vesical artery, and then sir superior vesical artery and ligated and divided.
So, so you keep on dissecting the ureter up to the ureteric hiatus. In the process, sir, next slide, please. In the process, you encountered the superior vesical pedicle, and you cut to reach the hilum, and then to reach the hiatus, and then you clip or ligate and cut the ureter over there, isn't it?
Yes, sir.
So when you have done both of these and the peritoneum is opened, the posterior peritoneum is opened vertically over the ureteric path, then what do you do?
Then we cannulate the both-sided ureter and keep like that. And after that, shall we go for the posterior dissection of the urinary bladder?
Can you do you always cannulate the ureter or keep the ureter ligated or clipped?
No, we always cannulate with
Can-
interference tube and kept with the gloves attached with it that so that urine collected in the gloves.
I think both is acceptable. Some center ligate, some center cannulate and leave the urine to drain. I think both is acceptable. So I think now we should move to the posterior direction that Dr. Devmalia is showing.
So we have reached now the posterior. What is the essence of posterior? What is the trick in posterior dissection? Both sides of peritoneum is now in a vertical manner, and there is a cul-de-sac between the bladder rectum. You want to join the two peritoneal, isn't it? What is your exact point of joining this peritoneal lines? What is your indication? What is the hint that these two peritoneal lines are to.
So at the level of the two views, we can, when the ureter has been separated, at that point we join the two peritoneum. And
What do you get here at the level of view? What do you get here at the posterior side of the bladder?
So Denon-Villiers fossa.
You get the tip of the seminal vesicle. This is your hint. If you can palpate or in thin patient, you can also see the tip of the seminal vesicles over here. So to expose the, you only cut a single layer of the posterior peritoneum. Sir, can we go to the next slide? You join the two incisions to expose the seminal vesicle, isn't it? So if you follow the seminal vesicle border, then you can reach the common lamella of the Denon-Villiers fossa, isn't it? And how do you reach over there? With a sharp dissection or with a blunt dissection?
The blunt dissection.
With blunt dissection using your two fingers, isn't it? Where
Yes,
you reach the proximal part of the prostate. Now, by doing this, what is the objective of doing this step? You do an posterior dissection now. You have opened the lamella bilaterally. What is the objective of this step? What is the next step you are going to with this step? That you are developing the two posterolateral pedicles. These are the branches from internal iliac artery which reaches the bladder and forms the superior vesical pedicle is already controlled. So you
inferior
control
pedicle.
the inferior vesical pedicle and the prostatic pedicle last. So at this juncture, you try to. What is your choice of doing lymph before the cystectomy or after the cystectomy?
After the cystectomy, sir.
So what are the
Before the cystectomy
and against of doing lymphadenectomy before cystectomy?
Sir, will
So many.
Someone is having a lot of noise. Can we stop that?
yes, sir. Please repeat the question.
So what is your choice of doing a lymphadenectomy before cystectomy or after cystectomy?
Sir, before cystectomy.
Why is that?
If we cannot adequately lymphadenectomy cannot be done due to dense adhesion, involvement of vessels, internal iliac vessels, then we can abandon the procedure and plan for chemotherapy. If we do not perform lymphadenectomy completely.
Is that so, Rohit boss?
See, there are many ways to skin a cat. There are many ways to skin a cat, but in intraperitoneal, dissection is done later on. Extraperitoneal, there is two ways. Actually, many ways. Actually, what you are describing is a retrograde approach. Now, people have also switched to antegrade approach, the dorsal vein first approach. So, it depends upon many things, what kind of philosophy your department is following. Like in our institute, we generally do lymph node dissection first and we do a dorsal vein approach first. So, our philosophy is different. So, it, visual things are different.
So even if we do an transperitoneal approach, we actually do the lymphadenectomy later after cystectomy. In that way, we feel that the lymphadenectomy becomes much easier when the bladder actually is not there. This is our philosophy. But it can be done before cystectomy or after cystectomy as well. So you have already developed the lateral pedicles. So one by one, both the pedicles are controlled either with an ligature or clips or with instruments. So what is the choice of instruments over here and why is that? What is your choice of instruments here and why is that?
For which steps, sir?
Controlling the lateral pedicles.
So we usually use a ligature in our institution for controlling of the sir, lateral pedicles, sir.
So you use a thermal instrument.
Yes, sir.
One can use clips only or one can use ligation
Suture.
only.
Yes, sir.
So is there a controlling method of lateral pedicles?
Sir, can I repeat? What is the question, sir?
Choice of using a controlling method for lateral pedicles. Will you use a thermal instrument or will you use clips and ligatures?
Sir, we usually use sir thermal instrument, but clips or ligatures are sir preferred.
Why?
So sometime after applying the thermal device, some bleeding is occurred from the sir, posterior and lateral pedicles.
Okay. So if you really targeting for a nerve preserving procedure, then it is preferable to use a clip or
Clips.
ligate. But if nerve preservation is not your priority, then you can always use a thermal device, isn't it? So what do you do after control of the lateral pedicles? You go to the base of the prostate in case of male, isn't it? What is your next procedure? What is your next step?
After that, sir, we have to identify the endopelvic fascia and dissect.
Next slide, please. Next slide, please. Sir. Yes. Yes.
Yes, sir. Sir, endopelvic fascia should be identified and by dissecting the fatty tissue over that and bilaterally we have to incise the endopelvic fascia and then sir you have to dissect and divide the puboprostatic ligament of both sides. And after that, sir, we have to deal with the DVC by ligating twice with the number 1 round body vicryl cell.
Okay. So you have went directly to opening the endopelvic fascia and going to ligate the DVC. Tell me the exact point in which you have to introduce your needle. What is the philosophy of introducing needle by for controlling of DVC?
And which kind of needle?
And which kind of needle? Yes.
So you have to palpate the prostatic apex of the prostatic apex distally and then sir we have with a carved needle sir at that prostatic apex region you have to sir take the bites take the suture.
What kind of curve needle? Half, 3/8, 5/8, 2/8, what?
Sir, 5/8.
Sir, 5/8
sir.
curve needle.
it is a CTX black needle of the PTS. That is very good. And you have to stand on which side when you are taking the dorsal vein?
Which side does
Lateral
the
to medial. Lateral to medial.
Where you
which side does the surgeon
Sir,
face doing this?
Left side, sir. Left side of the patient.
Left side.
cranial and
Facing the
caudal.
What, towards the patient's face or towards the patient's leg?
patient's face, sir.
The patient face.
So this is the step. So
Then
this
it
is
is convenient to take that suture on the caudal side, from the caudal side, not from the cranial side. Am I correct?
Sir, please repeat, sir.
You have to take the suture from the caudal side. You have to face, your face should be facing the face of the patient when you are taking.
Yes, sir.
Am I right, Himalaya?
yes, absolutely, sir. So this is the time when actually the surgeon faces the patient's face, not the patient's leg. Because if you are a right-handed surgeon, you will be standing at the left side of the patient, and mostly you will be work facing the patient's leg side. This is the time when you work the other way. And it is said that the entry point of the needle will be the notch between the bunch of DVC and the proximal urethra at the tip of at the apex of the prostate, isn't it? So that do not go through or along the substance of the urethra. Okay.
I will emphasize one that this is very important. Controlling the dorsal vein is very important, particularly if you are in the beginning of the curve, because the patient can bleed a lot if you have not controlled the dorsal vein. So a few tips I would like to add is that you should always take a 3x8 circle needle, a black needle, and the needle that you are using should be having a curve on the end, because that curve allows you to take the needle bit more caudal. If you take a straight tip needle, your needle will be bit cranial. If you are taking a caudal needle, it will go maybe 2, 3 mm or 4 mm more caudal, and that really makes your life easy. And dorsally, caudally, the vein spreads like a fan. So you should take a very adequate, wide, and a deep when you are taking a dorsal vein suturing, because that is the make and break. Here, at times, the surgery is lost because the patient can really bleed a lot if you have not really taken control of the dorsal vein. And you should keep the needle intact if it is bleeding, so that you can come back again and take the suture. So this is very important. Dorsal vein, I think this is the most vital step in the initial curve, because this is where the battle is lost.
Yes, this is the most important step. Your craftsmanship is tested at this step. Now, the most important, the more important step over here is, as Rohit Boss said, to keep the thread intact. You do not cut the thread, because when you start dissecting and separating the dorsal vein pedicle from the prostatic anterior surface, more veins will be opened and there will be bleeding. So keep the thread intact, keep on stitching unless all the bleeding is controlled. Am I right, Rohit Boss?
Yes. I think this is where laparoscopy is an advantage over open.
The pneumoperitoneum actually controls the bleeding. Now, the extent of mobilization of the prostate is up to at a point when you start seeing the urethra. Isn't it? This step is most important, and it actually determines whether you will proceed with a patient who is already, promised a neobladder. So you want to keep the urethra as long as possible. Now, while opening the anterior wall of the urethra, what will you do next? Anybody?
Sir, I will mobilize the prostate entirely, and then, sir, from the apex of the prostate, the posterior urethra, is sir dissected and sir divided.
Okay. So generally, what we follow is the standard practice that while the catheter is exposed, we keep the posterior urethral wall intact and posterior urethral plate intact. Then we actually dismember the catheter while controlling the cut part so that it's not deflated, and then actually do a sharp cut on the posterior urethral plate.
It is very important that in the intrapelvic part of the urethra should be at least 1.5 centimeter when you are planning for an orthotopic bladder, because that helps in the continence. That is one thing that everybody should remember. You should have a 1.5 centimeter of urethra inside the pelvis.
Okay. So what will be the adequacy of margin here? So the gross specimen has to be inspected after separating from the body. What will be the adequacy of margin? What is your impression of the specimen of adequacy of the margin? If the tumor is situated posteriorly, then our intact fascial layer should be there on the posterior margin, involving the seminal vesicles and the vas deferens, isn't it? And fascia has to be intact. So let us now come to the part of lymphadenectomy. Next slide, sir. Next slide. So it has been already discussed by Rohit sir that the boundary of the lymphadenectomy is deep iliac vein, distal common iliac vessels proximally, genitofemoral nerve laterally, and generally we take internal iliac artery. Can someone tell me about what is Marcelli triangle?
बोलो जाओ.
Marcelli triangle is the area between the division of the external and internal iliac artery, and the content of the triangle is actually obturator vessels and obturator group of lymph nodes. So whatever you do in standard lymphadenectomy, this Marcelli triangle, that is the area between the external and internal iliac group, has to be cleared so that the obturator nerve is seen intact. You may or may not salvage the obturator vasculature.
Only one question is where you can miss the lymph nodes? Where? What are the common sites? Means what are the precautions that you will take that you don't miss a lymph node? How will you make sure that I'm not missing a lymph node? To a Sashi, Asim, anybody, Wasim? Where you miss a lymph node? See, you on the lateral side of the external skeletonized completely. Then only you are sure that you have taken down all the lymph nodes. So that is the area where at times people miss lymph nodes to be dissected off. That is only one point I would like to say. This is the anatomy that should be seen, and also go on the lateral side of the external iliac artery and vein and make sure that all the soft tissues are clean from there.
From the surface of the psoas, the genitofemoral nerve has to be seen, but the psoas between the genitofemoral nerve and the external iliac vasculature has to be, cleaned up. These tissues must be removed. So we generally go up to the presacral lymph nodes. So mostly our boundary remains at the internal iliac vasculature and the pathway of the native ureter. What do you do after that? So let us keep it simple. The most common urinary diversion done is
ideal condition.
Why is that?
What is the gold standard?
What is the gold standard?
Actually, urinary diversion itself is a separate topic.
Yeah. I think it's a Sunday midday, so I think we can't get into that. But urinary diversion, we know what the gold standard is. Don't forget drain placement, close the abdomen and we take leave from you by closing this session. Thank you very much, Rohit and Devmallo.
Sir, I have a question, sir.
Yep, carry on.
Sir, in case of orthotopic neobladder, we have a, sir, the GFR must be around more than 60. In case of, sir, ideal conduit, what should be the, sir, limit of the, sir, GFR or?
Less than 60. There is no limit. Lower limit is not there.
The
we
lower
get-
limit is not there. The lesser the creatinine and the lesser the GFR is, you keep the conduit shortened.
Okay, sir.
You do not expose a large area of gut mucosa to it.
Sir, one more question is, sir, in case of, sir, prostatic stromal involvement, sir, you should mention that urethrectomy will be needed. Is it, sir? Then if, sir, in case after, sir, radical cystectomy, 25% of patients shows, sir, there is a prostatic stromal involvement, then what should be the, sir, next step for urethra?
That is an excellent question, I think, because the answer is given as keep the urethra under surveillance, but that urethra which has lost its connection from the main urinary conduit will not give you the ideal picture. Somewhere it is written that you can also follow up urethral cytology for follow up, but I think that's impractical.
Okay, sir. Thank you.
Okay, one final question that was asked to me in my MCH exit exam. If the patient has bled a lot and the BP is 70 systolic, you have just done a radical cystectomy, and the patient is not in a very good state, what are the other options that you have? 70, 80 systolic, you can't do orthotopic, you can't do ileal conduit because this was a question asked to me. What are the other options you have?
Sir, ureterosigmoidostomy, cutaneous ureterostomy.
Ureterosigmoidostomy, even you can do a bilateral ureterostomy.
You can do an ureterocutaneostomy.
He said that.
Ureterostomy.
Excellent. Can we have the permission to close this session with a few comments?
Yes,
My
sir.
observation is, and I'm sure Devmallo and Rohit will agree with me, excellent knowledge base from all the students.
Yes, sir.
Excellent presentation. But while we say excellent, we must also warn you, there are huge deficiencies in presentation. If you can correct that, you know everything. I mean, I don't think there is any iota of doubt. What you've said today and yesterday, I have no doubt that we don't need to increase your knowledge. It's the way you present and not fall into trouble. Please remember not to fall into trouble. Say things which you know, say things which you can justify. And you will just not only sail through the exam, you will sail through your life as a urologist. Good luck to you. Hope you enjoyed it. And thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.